Good morning. I'd like to thank everybody for the opportunity to present at your conference. My name is Laura Nichol. I'm a registrar in general surgery from Inverness in the north of Scotland. I'm going to present some results from a systematic review that we recently completed on the mesh in laparoscopic groin hernia repair. The review was conducted because the efficacy and safety across different types of mesh is still uncertain. We have no conflicts of interest to declare. So we searched the literature for relevant randomized controlled trials and non-randomized comparative studies that were published up until December last year. There was no restriction on language of publication, type of hernia, type of laparoscopic technique, or type of mesh. We used a meta-analysis to analyze our results and focused on the two most relevant outcomes to inguinal hernia repair: hernia recurrence and persistent pain. Our search strategy identified 653 studies which were screened, and after this 602 were excluded, which left 51 full texts for evaluation. After a detailed review of these texts, 7 randomized controlled trials and 4 non-randomized comparative studies were included for review. We classified mesh into 4 types: lightweight non-absorbable mesh, such as Dynamesh; heavyweight non-absorbable mesh, such as Prolene or Surgipro; partially absorbable mesh, such as UltraPro; and biological absorbable graft. This is a list of all the mesh that was used in the 11 included studies. As you can see, no studies used biological graft. So on to our results. This meta-analysis compared lightweight non-absorbable mesh versus heavyweight non-absorbable mesh. Included in this meta-analysis were 3 randomized controlled trials and 2 non-randomized comparative studies. After a median follow-up of 12 months, lightweight non-absorbable mesh had a slightly lower recurrence rate, but the difference was not statistically significant. We then moved on to look at persistent pain between lightweight and heavyweight non-absorbable meshes, and 2 randomized controlled trials and 1 non-randomized comparative study looked at this. In this, we found that lightweight mesh has a slightly lower risk of persistent pain, but again, the difference was not statistically significant. And all 3 studies included measured pain at 12 months. Next, we examined partially absorbable mesh versus non-absorbable mesh. Non-absorbable mesh here includes both heavyweight and lightweight. We found that the partially absorbable mesh had a slightly higher recurrence rate, and this was 2.4% versus 1.6% for the non-absorbable meshes, again after a median follow-up of 12 months. However, when we looked at the outcome of persistent pain after surgery, we found that partially absorbable mesh had a significantly reduced risk of persistent pain compared to non-absorbable mesh of 2.1 versus 6.6. So, in conclusion, there were no significant differences found in major outcomes between lightweight and heavyweight non-absorbable mesh. It would seem that partially absorbable mesh significantly reduces the risk of persistent pain when compared with absorbable mesh, but is associated with a slightly higher recurrence rate. Our recommendations from this systematic review is that there's a lack of high-quality randomized controlled trials comparing partially absorbable mesh and non-absorbable mesh. Some of the papers studied actually found no difference in major outcomes between these 2 types of mesh, and so further trials are needed in this area. Thank you very much.
The floor is open. If, excuse me, are there any questions from the audience? So after your analysis, what kind of studies should we be doing? What's going to answer this question for us?
I think we found that there was a lack of data available comparing the partially absorbable meshes versus the non-absorbable meshes, and I think that from the data we've gathered, it would seem that there's a benefit of using partially absorbable mesh, and that's where we should focus further studies. There's also a lack of evidence available using biological graft for review, and that should potentially be an area that's looked at as well.
So did, when you were evaluating pain, was it you may have mentioned this, was it a Likert scale? Was it, did you look at comfort scores? How did you evaluate pain?
We used the author's definition of pain, which was different in each study.
Yes.
Yeah, I had a question about the pain. The pain can happen for many reasons after a hernia repair done laparoscopically with a mesh. There are tacks placed.
Mm-hmm.
There are people who place a couple of tacks. There are people who place many tacks to close the peritoneum over the mesh. So in your study, did you encounter any differences if tacks were placed and that caused pain, or was it the mesh per se was the cause of the pain?
Thank you for the question. In the studies we looked at, not all the authors had disclosed if they'd placed tacks or not. We certainly didn't take that into consideration, but it's a good point.
Left microphone.
Julian Bigener, Rochester, Minnesota. Thank you very much for your presentation. How confident are you, based on your heterogeneity of the studies and the different variables that were not disclosed in the studies, that your results are actually representative of what's in there, and that a next trial or an institution should put a large amount of money into performing a large randomized trial based on your results? How confident are you that this is actually what it is?
Thank you. I think that the differences between the partially absorbable mesh potentially causing less long-term pain is an area that should be looked at. There were some studies that didn't show a difference at all. They tended to have slightly smaller numbers, but I think it's definitely an area worth researching to see whether the theoretical risk of the partially absorbable mesh causing high risk of recurrence is a sort of true factor.
Any other questions? Well, thank you. I think we've all struggled with the data on hernia repairs when problems are of such a low number, percentage in terms of risk and recurrence and pain, and you have to follow so many patients for so long. They're very expensive studies, so we wind up with these meta-analyses of the smaller studies. Thank you very much.
Thank you.